We are live.
Good evening, everyone. This is the February webinar for the Egyptian Pediatric Surgical Association. On behalf of myself and the board of the EPSA, we have two eminent speakers, and Professor Orkan Urgun, the TAPS president, and Professor Hisham Abdel-Qadir, and I will let the floor for Professor Dr. Sulaiman Mohammed Sulaiman, the vice president, and the Professor Ahmed Khairi, the chair of pediatric surgery in Alexandria. Welcome all participants from all over the world, and stay with us. We have a nice presentations today, discussions. Thank you.
شريف introduce.
دكتور سليمان.
ايوه
تفضل يا دكتور.
السلام عليكم ورحمه الله وبركاته.
عليكم السلام ورحمة الله.
عليكم السلام.
Good evening everybody. I hope you all are staying safe at your homes, virtually attending the scientific activity as we have usually been doing since the start of COVID-19 pandemic. Filled with pleasure and hope, I welcome you all to today's webinar. Your speakers is Dr. Sulaiman Mohammed Sulaiman, the Vice President of EPSA and is the former head of Pediatric Surgery Department at Al-Azhar University. Actually, I am over the moon to be among you all today, especially we are talking about an interesting topic that seldom we do discuss in our usual daily activities. As you might know, the experience and the resources in this field is a bit scarce, and sometimes it's a kind of missing the right way to get your patient safe. That is why we are facing a big dilemma of doubts and confusion in this field, especially when it comes to dealing with children. So today we are about to make it clear to the attendees how should you do a liver resection in pediatric population. For me, and I think for many of you as well, I find this is a tough topic, especially taking a decision to resect a part of a vital organ like the liver in a child is not an easy job. In fact, it's very serious, and doing the operation itself is a sort of a risky operation with high risk, bleeding and the liability to injure the vital structure all around. That is why today we are listening to two experts in this field who have done a lot of these liver resections, sharing with us their expertise and clearing the way to us to widen our understanding and resolve the debate surrounding this topic and show us some of their special techniques to do a safe and fast liver resection. I assure you, we are about to listen to well-prepared, up-to-date speeches that I am pretty sure that we make your day. Last but not least, I invite you to give our speakers your attention to benefit from their knowledge and experience. At the end, please let me introduce our today's speakers today. Firstly, we have Dr. Hisham Abdel-Qadir from Egypt. He is a professor of pediatric and hepatocellular surgery at Ain Shams University in Egypt. He was a research fellow of pediatric liver transplantation, St. Luke University, Catholic de Louvain, and Royal Hospital for Sick Children in Glasgow. He is a member of Royal College of Surgeons in England and has got the European Board of Pediatric Surgery. He is also a reviewer at the Annals of Pediatric Surgery Journal. Dr. Hisham, the mic is yours.
Thank you, Dr. Sulaiman, for the nice introduction. And it's a pleasure for me to be here with you tonight on this, sharing my humble experience with you in topic of liver resection in pediatrics. So I'll go directly to the my presentation. As agreed, I'll start with doing what we should be doing all, getting the principles. We are dealing with a tough topic, which is the pediatric liver resections in children. So first, we should ask ourselves, what are we doing? Do we know the liver? What is the segment? What is the normal anatomy of the liver? So every surgeon who's about to start his career in doing liver resections or liver surgery in general should be vastly aware of the segmental anatomy of the liver. And we know that the liver is divided into 4 sectors and 8 segments. This is the Coino classification of the segmental anatomy of the liver. And how to interpret this on our everyday practice when we see a CT scan or an MRI scan, how to know which segments of the liver are we speaking about, if the tumor or the mass is occupying a certain sector of the liver or a certain segment of the liver, what are the segments on the CT scan, and how to interpret this. So if we see a scan, for example, and we want to determine if the for example, the left lateral segments 2 and 3 are the involved segments. So roughly we extrapolate a line from the falciform ligament to the insertion of the left and middle hepatic veins into the IVC, and that should cover the sectors of 2 and 3 sectors or the left lateral segment. And of course, when we try to embark on doing like a right hepatectomy, so segments 5, 6, and 7, and 8 are the involved segments. So we draw another line, which is the Cantl's line, where the middle hepatic vein is, and it's a line that passes from the gallbladder fossa to the to the insertion of the middle hepatic vein in the IVC. And that should give us an idea on the future remnant liver, how much is left for the patient after we do our resection. If you're going to do a liver resection, you should be familiar with the anatomical variations, because there are many anatomical variations, whether they are in the arterial segment, the biliary system, and many variations in the biliary system, the portal, which are not as much as common as the other two, and of course the hepatic venous anatomy. You should be familiar with all the anatomical variations in all of them. So again, we ask ourselves, why are we doing liver resections in children? So there are some or few indications. Hepatic malignancy, of course, are the most common, hepatoblastomas or hepatocellular carcinomas. Some hepatic benign tumors like hemangiomas and hemangioendotheliomas are common, and sometimes we face them and we decide to resect some of them. In the misfortunate event of having a traumatic liver rupture, sometimes you're forced to do some hepatic resections to control the bleeding. Some chronic infections, liver disease, and of course, hepatic cysts like hydatid cysts. So I'm sure that every surgeon would ask himself, how should I do a liver resection? How to prepare my patients beforehand? So I have to assess the patient general condition. I have to assess the cardiovascular and pulmonary functions. But of all, the most important is how to assess the liver reserve. How much are you going to leave for the patient, and is it enough for the patient to survive after surgery? Because liver failure after doing a hepatectomy is something that is very dear and it's very difficult to deal with. And after doing these preparations, you'll decide which operation are you going to do. If you're going to resect, for example, segment 2 and 3, you're doing a left lateral trisegmentectomy. There are many nomenclature for the operations, but do not be puzzled with the names, rather than knowing the segments and which segments are involved and how much are you going to resect of the liver and how much are you going to leave for the patient. I guess that there are certain steps that you should be familiar with when you go to the surgery. For example, intraoperative ultrasound is one of the key skills that you should know beforehand before doing a hepatic resection, because you should avoid injuring vital structures on your way, and doing an ultrasound inside the operating theater on the liver directly itself should know or gives you an idea on where are for the middle hepatic vein, for example, to avoid injuring such an important structure. Doing an intraoperative cholangiogram is very important inside the surgery, because you should know beforehand how's the duct system looking like, the variations in the anatomy. There are certain tricks that you can do is before dividing the biliary system, doing a cholangiogram and then putting a clamp over where you are going to divide, and then doing a cholangiogram again and making sure that you are not taking with you the right side, for example, or doing harm to an important duct system. The methods of vascular control, you should be very familiar with them. There are many different types of vascular control. Inflow or total vascular exclusion. The inflow, for example, the Bringel maneuver, which is the oldest one and the commonly used, whether continuous or interrupted, and you should be aware of what are the advantages and what are the disadvantages of every one of them. If you're going to do an ischemic preconditioning, you should know what are the differences between the ischemic preconditioning and the continuous, for example, Bringel maneuver. And more specific, that if you're going to resect, for example, the right lobe, doing a selective or a hemi-hepatic clamping, a hemi-Bringel maneuver is much more advantageous to the patient, and it will draw you a nice, clear demarcation line on the resection margin. But again, in some certain conditions, you should know if you're having excessive bleeding, how to do total vascular exclusion and putting clamps over the infra and suprahepatic IVCs, again with the inflow to lessen the bleeding. So in these conditions, you have to know how to completely mobilize the liver and how to encircle the supra and infrahepatic IVCs for your clamps to be ready. Selective vascular control is much more better if you know your way and how to isolate selective inflow and outflow of each pedicle, right or left. And sometimes you are faced with major bleeding from the IVC, and infrahepatic venal clamping should give you a nice view to isolate your bleeding points. Some knowledge about the high dissection of the porta hepatis and ligation of up to the second order branches of the portal and arterial vessels would be very advantageous if you're going through the journey of doing a liver resection, and to know how to do a Glisonian pedicle approach, which is the basic now science for doing a segmental liver resection, because coining the Lanix capsule quotation is very important to know that there are differences between the Glisonian pedicle, the liver capsule, and the Lanix capsule, which is encircling the inflow of the liver. And so you should be able to know how to isolate selectively the anterior, for example, the anterior pedicle of the right lobe or the posterior pedicle of the right lobe, or doing a left lateral segmentectomy. Hanging maneuver of the liver is another specific maneuver that you should know, especially if you're going to start your journey with doing a laparoscopic liver resection, because you will have to hang the liver to do a liver resection, and to know the avascular plane of the retrohepatic IVC, where should you pass your sling to hang the liver without injuring any of the retrohepatic IVC structures. And of course, you should know a word or two on how to do a proper parenchymal resection. What are instruments are you going to use? The CUSA, the Cavitron ultrasonic surgical aspirator, the harmonic scalpel, and the ligature. What are the differences between different modalities of them? The Habib needle, or the multi-probe bipolar radiofrequency, and the water jet, which I personally haven't seen a lot, especially in our country. You should be familiar with using the vascular staplers and controlling the whether the pedicle or the outflow of the liver and know the differences between the cartilage size. And of course, again, you should be familiar with the hemostatic agents that you can use over the cut surface to control bleeding from them or from bleeding sites. And eventually, you should be again familiar with how the sequence of the patient in the post-operatively. You should know that the enzymes usually are flaring or high rockets in the sky immediately after the surgery, and they start to normalize after the 5th day, and they should be normal by the almost 2 weeks. That the INR or the coagulation profile starts derangements immediately, like the second post-operative day, and then gradually becomes normal over the next few days. So you should be aware what is the scenario, how is your patient progressing, especially in the ICU, to be able to monitor the patient in the ICU. And a word or two on the complications or the morbidity and mortality that you are expected to deal with. Blood loss, biliary leak, what is the grading of the biliary leak, how you diagnose biliary leak, which is if you have bile in the drain more than 3 times the serum bilirubin after the 3rd post-operative day, how to deal with it, whether endoscopically, whether percutaneous ultrasound or CT-guided aspiration, when are you going to do surgery again for biliary leak, what is the definition of liver failure after the surgery, how to deal with post-hepatectomy hemorrhage, surgical site infection, ascites. There are many morbidities and mortalities related to the procedure that you should be preparing yourself to deal with each of them. And finally, a word or two on large tumors, whether you're going to stretch the limit of safe resection. What are the advancement techniques now that you can make tumors that were irresectable before and they were transplanted, or I mean referred to transplant. Now transcatheter arterial chemo and radioembolizations are making our life more towards doing resections for irresectable tumors. There is now many reports emerging that the liver partition and portal vein ligation, which is a staged hepatectomy, can do the trick for large tumors that were deemed irresectable before and were transplanted from the start. And you should be also aware of that when you should transplant the patient and when not. So I guess my dear Professor Orkan will be speaking about the indications for transplant in liver cancer. And this is just to show you that there were some research done from our part about hepatic resection in children, if you care to look it up in the literature. Thank you, and I share my presentation now to Dr. Orkan.
Please, Akram, let unmute Dr. Ahmed Khairi.
Thank you, Professor Sham, for this nice presentation, which is about the basics for liver resection. And now we move to our guest speaker, Professor Orkan. He's a professor of pediatric surgery in Ege University Faculty of Medicine in Turkey. He's been graduated from the Faculty of Medicine in 1992 and specialized in pediatric surgery in 1998. He's along his career as assistant professor and then research fellow in pediatric surgery in Pittsburgh in United States, and then associate professor of pediatric surgery in Ege University, Turkey. And then he's affiliated for Ege University Solid Organ Transplant and Liver Transplantation Unit, and professor of pediatric surgery in Ege University in 2012, and the head surgeon of liver transplantation unit. And now he's the president of the Turkish Association of Pediatric Surgeons since 2017 up to now. So, Professor Orkan, we are all eager to listen to you.
Thank you, Dr. Hariri, for the very nice presentation. And I'm really very honored to be here among with you friends. And it's very exciting for me to speak before you tonight. Just a second, let me try to share. So if you can see my slides. I would like to thank also Sharif and the Egyptian Association of Pediatric Surgeons for having here tonight for this webinar. And I'm really flattered. So I will be talking about liver resection in pediatric hepatic masses and a brief surgical update. And my presentation plan will be as follows. I'll briefly point out the place of liver tumors among others, and again, briefly go over some basic surgical anatomy as Hashem did, and then there will be some information about staging of the liver tumors. And since hepatoblastoma is a prototype liver tumor in children, I will talk about some patient examples to clarify the patient selection. And very briefly, I will talk on hepatocellular carcinoma. So as Hashem also mentioned, 2/3 of all liver tumors in children are malignant, and most of which are hepatoblastomas, and we rarely see hepatocellular carcinomas. And among benign tumors, we see hemangiomas, hemangioendotheliomas, hamartomas, and so forth. So in adults in the United States, cholangiocellular cancers are the leading liver cancers, followed by the hepatocellular cancers. It's estimated to be around 2.1 per 100,000, whereas in children, hepatoblastoma appears only 1.5 cases per million, and followed by the rare kind of liver tumor being the hepatocellular carcinoma. And also liver tumors in children have close relationship with genetic syndromes like Beckwith-Wiedemann, familial polyposis, Li-Fraumeni, most of which are hepatoblastomas, as well as they have some relationship with metabolic syndromes such as glycogen storage disease, tyrosinemia, cholestatic syndromes, and mitochondrial liver diseases, most of which are the hepatocellular cancers. So as Hashem pointed out, this is the liver, and the liver constitutes about 2 to 2.7% of the total body weight in a human. And the liver is again separated into two lobes, as being the right hemoliver and the left hemoliver. The right hemoliver constitutes the majority of the liver mass, being the 2/3 of the whole liver, whereas the left hemoliver is only 1/3 of the liver. And then there are the sectors again, of which the left lobe has lateral and medial sectors, and the margin of the left lobe and right lobe is divided by the middle hepatic vein usually, and the right hepatic vein, the right liver is divided into anterior and posterior sectors. And also Hashem mentioned about the segments of the liver. When I was a resident and also a new pediatric surgeon, I was always confused about the numbering of the segments, but there's a simple way to do it. When you look at the liver from above, the numbering goes in a clockwise rotation like this: 2, 3, 4, 5, 6, and 8. And when you lift the liver up and look from below, it goes in a counterclockwise fashion like this. So if you memorize like this for the junior staff in pediatric surgery, it's much easier. And then the hepatoduodenal ligament houses bile ducts, hepatic arterial system, portal vein at the most posterior position. And as Hashem very beautifully mentioned, a surgeon must be familiar with the anatomical relations and variations of these structures. And if a failure to do so may easily get the surgeon into trouble during surgery. So the surgeon, hepatobiliary surgeon, has to know what he's doing rather than improvising. And the arterial system has many variations. These variations have been described in the late 50s and 60s. And this is the normal anatomical appearance of the arterial system arising from this celiac trunk. but there may be variations such as the left hepatic artery may arise from the left gastric, and in another variation, the right hepatic artery may come from superior mesenteric artery, and the left artery may come from the celiac trunk. They both may come aberrantly, being the right hepatic artery from the celiac from the superior mesenteric artery, whereas the left artery may come from the gastric artery, or the total system may be totally replaced, all coming from the superior mesenteric artery. So while doing a resection, we should be aware of all these variations, and you should also know how to deal with these variations. And also hepatic veins are very important. The right hepatic vein, draining the majority of the right lobe, drains directly into the vena cava, whereas the middle hepatic vein and the left hepatic vein come into a trunk usually, and then drain together into the vena cava. And there is usually a bare space between the right and the trunk. This is the space where we do the liver hanging maneuver. There's also one important ligament called the inferior vena cava ligament, or hepatocellular ligament, or Makucha ligament, coming from the caudate lobe to the bare area of the right hepatic lobe. This ligament has to be dissected and divided freely to get access to the right hepatic vein. But behind this, there may be an accessory right inferior vein, which is also called the Makuchi vein. And while dividing this ligament, if you fail to recognize the vein, you may end up with fatal bleeding or air embolism. Also, there are some short hepatic veins that need to be divided while dissecting the cava and doing the major vascular control. So one important thing also in hepatobiliary surgery is a large enough incision. Attempting a big surgery from a small incision does not count here. So I usually do not hesitate to do a Mercedes incision for liver resection to have a good exposure to all vital structures in case an accident occurs. So the dissection and the surgery starts with taking down the falciform ligament until exposing the hepatic veins and suprahepatic vena cava, as you can see here. And then when you lift the liver up, you take down the peritoneal surface lateral to the hepatoduodenal ligament, and this exposes the infrahepatic vena cava, as you can see here. And then you should go around the inferior vena cava, not going too much down to disturb the renal vein, and also taking care of sparing the short hepatic veins. This provides the control of the inferior vena cava, the infrahepatic vena cava, and then short hepatic veins need to be ligated carefully to start dissecting. This is called the piggyback dissection. And then you will come across these small hepatic veins that draining small pieces of the small segments of the right lobe. These need to be divided and ligated carefully. And then if you need to, you may also ligate the adrenal vein to have a good control of the, better control of the vena cava. And as you move up, you divide the Makuchi ligament and Makuchi vein. And then when the piggyback dissection is completed, retrohepatic space is completely exposed for you. And this is the vascular control of clamping the inferior vena cava and superior vena cava. That's a total exclusion of the vena cava while doing a resection. If you need to do this, or we do this in the transplants. And there's also the Cantley line. He also mentioned this. The Cantley line extends from between the right hepatic vein and the middle hepatic vein all the way through the vena cava to the bed of the to the gallbladder. We pass a Penrose drain or a rubber tape to do the liver hanging maneuver, and then we mark the margins with the Cantley line, separating the right lobe from the left lobe. So controlling the pedicle, selective controlling of the pedicle, provides ischemic area to delineate. I'm sorry, to delineate better the area that you will provide to resect. And then the dissection is performed by using the instruments Hashim has beautifully mentioned. So after these technical small details, I will go into the hepatoblastoma, and I will try to proceed with how to manage the liver masses in children. As I said previously, hepatoblastoma is a prototype tumor in children. So I will give some patient examples as well to provide some insights. Hepatoblastoma is the most common liver tumor in children, and it's usually seen in infancy. The newly diagnosed cases seem to have increased over the years in the world and in also Turkey. The hepatoblastoma usually involves the right lobe. However, it may be bilobar or even metastatic at the time of presentation. So staging is very important. There are various staging systems. The most commonly used ones are SARPAL and COG, which is Children's Oncology Group. There are also Japanese and German staging systems, but they're similar in terms of the major things. So I will usually go through the SARPAL system, but between the SARPAL and Children's Oncology Group, there are some major differences, such as the SARPAL system uses the pre-surgical staging, whereas the Children's Oncology Group uses the post-surgical staging system, and I'll clarify that in a moment. For SARPAL, all patients except for stage 1 patients receive preoperative neoadjuvant chemotherapy, and only stage 1 patients receive primary surgery. Whereas in COG, all patients receive primary surgery and there are staged afterwards, followed by chemotherapy. So this is the major difference. So for the SARPAL staging, we use the pretext staging, which is the pre-treatment extension of the tumor within the liver, using ultrasound and MRI. However, sometimes MRI has breathing artifacts and patient incompliance, so this may be better clarified. The tumor may be clarified by angio-CT as well. As I mentioned before, only pretext 1 tumors receive primary resection, whereas all the other stages receive initially neoadjuvant chemotherapy and then surgery. I will go over the stages now. When I say pretext 1, the tumor involves only single sectors, and all 3 sectors here or here are spared. Whereas on stage 2, pretext stage 2, the tumor involves the 2 sectors and 2 adjacent sectors are spared, as you can see. There are some variances, of course. On pretext 3, the tumor involves 3 sectors or 2 different sectors, but there's only 1 sector that's spared, non-adjacent sector. And pretext 4, as you can imagine, involves all 4 sectors of the liver. Additional to these parameters, the staging of the system, the hepatoblastoma, we also search for these parameters, which are the involvement of vena cava or hepatic veins, the portal vein or portal bifurcation, the caudate lobe involvement, extrahepatic extension of the tumor, and metastatic extensions. The presence of any of these parameters does not change the pretext staging. However, these affect the risk of the patient and also the prognosis of the patient. So this is a stage 1 tumor involving the lateral sector. And as you can see here from below, and this can be simply resected. And lateral sectorectomy is curative in this case. You can do an open surgery, and also this can be done laparoscopically. I'll try to show you a short video of laparoscopic resection of lateral sector. It starts with exposing the ligaments and then exposing the portal venous structures going to segment 2, as you can see here. And also here's the left lateral artery that's perfusing the lateral sector. Then these structures are clipped and divided. I will skip some of these pieces in order to save some time. For the dissection, you can use, as Hashem mentioned, the ligature. You can use.
You can have the time. You can take present.
I think I'll make it. I think I'll make it use the time efficiently. We tend to use either harmonic or ligature. This can be done in a similar fashion to open surgery, and we also use the crushing of the tissue to better expose the small vessels. And these can be sealed easily by ligature or the harmonic scalpel. After dividing the parenchyma and after ligating the segment 2 vasculature, you will come across the segment 3 vessels. Here, the segment 3 vein now. This is again clipped and divided. And then you will come across the bile system. We should take care not to seal the bile, but rather clip it. This is the bile system. This is the inferior part of it. Right, here's the bile duct coming from the lateral sector. So it's clipped and then divided. And after dividing this, the parenchymal dissection continues. You see the small bile coming out. I'll skip this again. And then the parenchyma is divided again, and you will come across the right hepatic vein afterwards, as you can see here. Then you encircle, go around the right hepatic vein very carefully, and then you can use a vascular stapler to divide the hepatic vein, and then all the vessels are sealed. So it's safe to go through the parenchyma, taking all the liver out. And then the cut surface can be cauterized by bipolar or monopolar. And then the liver or the specimen can be placed in an endobag like this. And it can be retrieved from one of the choker sites. So this is a case of, this is a tricky case because it's debatable whether this is a stage 2 large tumor compressing the medial sector of the left lobe, or is a large stage 3 tumor involving the left lobe. You cannot sometimes decide whether stage 2 or whether stage 3, but that really actually doesn't matter. Of course, I mean, the staging is very important for the surgical diagnosis. But anyhow, these cases are eventually going to receive neoadjuvant chemotherapy, which will reduce the size of the tumor. So post-text staging enables that this tumor is limited to the right lobe. So a right hepatectomy can be performed, as you can see here. And this is the vena cava. All the small short hepatic vessels are clipped. And this is the left lobe remaining. As I said, we use the Mercedes incision, and this is the healing of the incision. It's not so bad. Sometimes the tumor may invade the local structures, the adjacent structures, as in this case. This tumor invaded the diaphragm. After receiving the chemotherapy, we aim to operate. Of course, every possible attempt to take out all the lesion should be done. So in this case, we had to take out the diaphragm with the tumor. As you can see here, the lung is exposed. However, it was possible to take out the tumor with right hepatectomy as well as diaphragm resection. And after hepatectomy, we repaired primarily the diaphragm. And this kid is still alive. He's still fine. And this is a large case, as you can see. And sometimes the tumor can be really troublesome, and you can really extend and force and stretch the line of the safety of the surgery. So this is a very huge tumor after chemotherapy, and this had a very poor response in terms of reducing in size and vascularity. And you will see this is a huge tumor, also invading the hepatic flexure of the colon. And by seeing the liver safely preserved above the tumor, we thought this could have been maybe a retroperitoneal tumor and misdiagnosed and mistreated. So we sent a frozen biopsy from here, and unfortunately this was a hepatoblastoma. So we had to do every attempt to resect the case, and we actually could manage to take the right liver together with the adjacent hepatic, the colonic flexure. And as you can see, the left lobe could have been preserved in this case. So majority of hepatoblastomas may not be suitable for resection at presentation. However, 85% of those cases become suitable after neoadjuvant chemotherapy, which reduces the size, the vascularity of the tumor, as well as metastases disappear. So also, some of the cases require transplantation rather than excision. And the indications for transplantation in hepatoblastoma, for example, include all pretext 4 tumors that are involved with all the lobes, and also the pretext 3 tumors that are in close relationship with vascular structures and or intravascular extension or invasion. And I will show some examples of those cases as well. And these cases that are requiring transplantation need to be listed for liver transplant. If they have a living related donor, they should be prepped. And then the chemotherapy should immediately be started. So this is a case with a right-sided, right lobe involvement hepatoblastoma. And after receiving the chemotherapy, the tumor was really delineated in the right lobe. So we went in to do a right hepatectomy. But to our surprise, when we opened the case, we saw that the tumor extended to the other sides of to the left lobe by intrahepatic metastases. And these were not reflected to radiologic imaging in this case. So this patient seemed initially a good candidate for right hepatectomy. However, this was not reflected on radiology. For transplantation, but this one was reflected. So this was a surprise case. So what we did is we confirmed that these were metastases, and then we closed the case. We prepped the mother for transplantation, and then the kid was transplanted. Sorry. This is an interesting case. This case was a right central hepatoblastoma. And after 4 courses of chemotherapy, this tumor shrinked in size, got limited to segment 4 and 7. However, this tumor was encasing the portal system. So actually what we should have done in this case was primary transplantation. However, this kid has such a poor family support that we decided to perform a resection because we thought that by looking at the family and discussing with them all the conditions, the family was not going to be able to take care of the kid and transplanted liver. So we did a extended right hepatectomy, and he was fine for 6 months. And at the end of 6 months, the tumor came back on the remaining liver. So we finally decided that we have to do the transplant, otherwise we were going to lose the kid. We prepped the mother, and we transplanted the kid from his mother with a lateral sector. However, the tumor came back 3 months later in the transplanted liver. So this was a lesson learned. So if there is an indication for transplantation, it's best to attempt as a primary transplant, because the salvage transplantations have a low success rate and it's below 30%. So if the kid requires transplantation, do the transplantation. So by the lessons learned from the previous case, we had another case that the hepatoblastoma was encasing the retrohepatic vena cava. So we decided to do a primary transplantation in this case. However, this case did not have a donor. I mean, the mother and the father was not suitable for being a donor. So we had to buy some time. To do this, we asked the invasive radiology to a transarterial chemoembolization, and she was stable until we got a cadaveric infant donor. Here you can see the encasement of the vena cava, like this. So when we resected, you can see the vena cava and all the hepatic veins are encircled by the tumor. And this case was transplanted, and she's fine. And this is a stage 4 tumor. No doubt this needs to be transplanted. So we transplant patient with a cadaveric donor and doing fine now. So if we want to take a look at the prognostic groups in survival, pretext 1, 2, and 3 tumors with no additional risk factors have a 3-year event-free survival of 90%, whereas pretext 4 tumors with high risks factors, older age, higher AFP levels, or low AFP levels, vascular involvement, and so forth, or unfavorable histology, have a survival rate of 50 to 70%. And our results have shown that our 5-year survival in our series is around 85%. So changing gears to hepatocellular carcinoma after some hepatoblastoma discussion, it usually occurs in adults with underlying cirrhosis, mainly due to hepatitis or non-alcoholic steatohepatitis. In children, however, metabolic liver diseases such as tyrosinemia and glycogen storage disease is the leading cause of hepatocellular carcinoma. It has a very typical appearance in the liver with a high arterial enhancement, contrast enhancement, and rapid venous washout. So there are also Milan criteria in hepatocellular carcinoma. Which patient needs to be resected or which patient needs to be transplanted is what's described by Mazzaferro in 1996. And if the patient has a single nodule that's smaller than 5 centimeters, or up to 3 nodules smaller than 3 centimeters each, and no macrovascular involvement, are good candidates for liver transplantation hepatocellular carcinoma. And pediatric hepatocellular carcinoma is the second most common liver tumor after hepatoblastoma. It peaks at school age and adolescence. And as I mentioned before, cholestatic liver disease and metabolic liver diseases are the leading cause of predisposing factors. Also, some come after viral hepatitis. And there's also one specific form, which is de novo, which has no previous history of an underlying liver disease. And this is called fibrolamellar hepatocellular carcinoma, which is usually seen in adolescent age on a non-cirrhotic liver. So the metastases, the presence of metastases and multifocality in hepatocellular carcinoma is associated with a very poor outcome. And it requires multimodal treatment, including neoadjuvant chemotherapy, surgery, sometimes in selected cases, transarterial chemoembolization and radiofrequency ablation. And the patients that are suitable for liver transplantation should receive liver transplantation, taking the Milan criteria into consideration. So this is a case of tyrosinemia. In the follow-up of this metabolic disease, the patient developed a nodule in the liver. And we're not really quite sure whether this was a regenerative nodule or a hepatocellular carcinoma, because the radiology was indefinite. So we prepped the case for liver transplantation. We prepped the donor. We opened up the case, and I took an excisional biopsy of this nodule, as you can see. And the frozen biopsy came as a hepatocellular carcinoma. So we opened up the case. You see the liver. It's very cirrhotic. And we transplanted the case with a lateral sector from the mother, and the procedure was curative. The specific form of the hepatocellular carcinoma, which is fibrolamellar hepatocellular carcinoma, is a rarer one and less aggressive form of hepatocellular carcinoma, and it has no viral etiology or liver cirrhosis. It's an interesting tumor because a series that appeared from Pittsburgh, this is a very large series from Pittsburgh. They performed 28 resections in 41 patients and 13 transplantations. And to our surprise, really, the survival rate in transplanted patients was significantly low. And the reason for this was being the patients receiving transplants were advanced stage cases. So in advanced patients, advanced stages, this procedure this disease can also be very fatal. This is a solid tumor with lamellar form of appearance on the CT. And also it's highly vascular, as you can see on the Doppler ultrasound here. It's rock hard. It is highly vascular, as you can see here. And this is the excised specimen of the fibrolamellar hepatocellular carcinoma. It's a very interesting type of hepatocellular carcinoma. And these tumors also can be centrally located on segment 4. However, these tumors can let you do a central resection. I would not recommend to do this on hepatoblastoma, because leaving any remnants of even a microscopic remnant on the vascular structures in hepatoblastoma means recurrence. However, these fibrolamellar form of hepatocellular carcinoma are very well delineated. and they can be taken out by segmental resections and also central resections. And if you have the skills and enough knowledge and intrahepatic navigation, then you can attempt to do a central resection. But I would still recommend to be very careful on doing a segment 4 resection because it's very tricky. And you're going to be dancing around the bowel structures and portal structures, and you can always get into trouble. And this is how it looks. And one last thing, this is the FNH, focal nodular hyperplasia. These are benign nodules that can also be multicentric in the liver, and they have a very nice pseudocapsule, so they can easily inoculate it. We usually tend to follow up these unless they're very large or they're very symptomatic. So in our 10-year experience with solid liver tumors, we operate on 87 tumors. 41 of them were hepatoblastoma. We did 33 resections, 8 of which were primary resections, and 8 liver transplants for hepatoblastomas. And we had 2 exes preoperatively during the chemotherapy course. They could not get to surgery. We operated on 10 fibrolamellar hepatocellular carcinoma, focal nodular hyperplasia, adenoma, and some more rarer tumors. And last but not least, solid tumors of the liver are rare in childhood and require special approach. And preoperative staging is crucial, and identification of the risk factors are very important. Multidisciplinary approach is mandatory in these cases, and surgery of the liver tumors, as I mentioned, as Hashim mentioned, are not easy. So pediatric hepatobiliary expertise in transplantation facilities increase the benefit from surgical management of the patients. And as the last slide, we're going to have, hopefully, we're going to have our annual meeting of the Turkish Association of Pediatric Surgeons in November in Antalya. So I would love to welcome you all, if you have the chance to come and visit us in Antalya for this occasion. Thank you very much. And I was very happy to speak here, and I really would love to host you here in Izmir anytime you like to come. Thank you very much again.
Thank you very much, Orkan, my dear friend, Tashakure, and I will leave the things for our moderators and chairs. Welcome.
Thank you, Sheriff.
Thank you, Professor Orkan, for this very interesting presentation. And now I guess we have to open the floor for questions. Do you have written questions, Dr. Tamer, or?
Muhammad Abdulaziz.
Okay. I will start, Dr. Ahmed.
Dr. Muhammad.
Good evening, everyone. It's my pleasure to welcome our outstanding expert, Professor Orkan and Professor Hisham. And on behalf of all the audience, I would like to thank them for their outstanding and illustrative presentation. First, I will start with Professor Hisham. I will pass to him some questions. Actually, very few questions because he speaks about the basics. Professor Hisham,
Yes.
You mentioned some intraoperative tools to guide you during the resection. Which is the most important for you, intraoperative ultrasound or cholangiogram?
They are not interchangeable. I mean, you have to know both of them. Yes, because the ultrasound determines the anatomy of the vascular structures. The intraoperative cholangiogram is for the biliary anatomy, so they are irreplaceable. I mean, one cannot replace the other. But the trick is the intraoperative cholangiogram is very important, even if you're doing a left side, because when I started training, they said that the intraoperative cholangiogram is done only with the right ones. When you do a right hepatectomy, you normally dissect the gallbladder out and use the cystic artery for that transcystic artery catheter and do a cholangiogram. But again, this is not right. If you're encircling the biliary structure and you want to know for sure that you're in the right spot, you have to do a cholangiogram. And the other thing is a cholangiogram either before cutting the duct or after finishing the surgery, to make sure that you're not missing a hole there or a hole there, and not leaving a chance for a biliary leak is very important.
Okay, thank you. During vascular control, if you decide to do a total vascular exclusion, for how long you should put the vascular clamp, and for how long should the liver stand this ischemia?
Children usually stand the vascular exclusion better than the adults, but of course, before doing a total vascular exclusion, you have to be online with your anesthetist, and he has to be ready with the IV fluids, with the because there is sudden drop of the cardiac output, like 15-20%. So your anesthetist has to be ready. Usually half an hour is acceptable, but doing a total vascular exclusion is in certain conditions. When we're doing a transplant, when you're doing a difficult recipient or native liver hepatectomy, sometimes we do total vascular exclusion and cut wherever holding the liver from the back to the IVC, and then while doing the total vascular exclusion, we suture the holes in the IVC and make sure that we're not missing anything. But usually it is better and undertaken in children than in adults.
Okay, thank you. Using sealing devices, we are familiar with harmonic and ligature, but CUSA, are you prefer to use it?
CUSA is a very nice device, especially around important structures, because it evaporates the hepatocytes and the parenchyma and leaves the important structures. So whenever you know for sure beforehand or after doing an intraoperative cholangiogram that there is a vascular structure or a biliary structure here that I need to take care of and not to injure, so it's better at that point that you use harmonic together with something like a bipolar clamp to just cauterize the small bleeding points. But CUSA is a marvelous device in your hands. If you know what are you doing, it's a marvelous device.
Okay, thank you. Which is more difficult to deal with, biliary leak or blood loss?
Going from hell to
another hell.
Well, of course, blood loss during the operation. Sometimes you injure something and it's done. You're losing the patient. So it's if you're referring to that situation, I definitely would not like to see myself in these shoes. Biliary leaks can be dealt with either intraoperatively, either post-operatively with the interventional radiology or another revisional surgery. But of course, blood loss is something that you would not like yourself to see.
Yeah. Okay. What are the indications of staged resection? Is it a solid indication for a staged resection?
Well, I've not done one myself, but I've seen indications are that the large tumors that involve the right lobe and the left lobe, sometimes now you can do, you go into surgery, the first stage, you do partition. Partition is like splitting. You split the liver into two halves. The right lobe, which is the main tumor, is in it. You divide all the inflow and outflow of that segment, and you do selective non-anatomic resection for small bits and pieces or satellites or whatever on the left side, and you leave everything for 2 weeks, and then you go back again, take out the right lobe, and you see that the left has grown in size, and the future remnant liver is what you can expect that the patient will survive with.
And at that moment, you can shift to transplant, or you can do this kind of thing?
Of course, the backbone of the whole procedure is that you have a graft ready. I guess so, because again, liver failure post hepatectomy is a dreadful complication that you would not like to see.
Last question from Professor Sharif Shahata. Can you please elaborate more on the volumetric evaluation and the post-operative lab for post-hepatectomy?
The volumetric evaluation, you mean pre-operative, the CT volume? Usually here in Egypt, we do the CT volumetry. They have a nice calculated software in the radiologists know that they can calculate the size of the tumor in milliliters and the size of the future remnant liver in milliliters, and they give you a percentage between the future remnant liver and the whole liver. We can accept like 25% of the future remnant liver, but usually in Egypt we do it a CT volumetry. For the labs, you mean the post-operative, the course? We usually have a pattern after hepatectomy. Immediately after surgery, you would see the enzymes very high, you would see the lactate is high, you would see that the coagulation is not perfect. And they usually normalize within the first 10-15 days after surgery.
Thank you, Dr. Hisham. Now I shift to Dr. Tamer, please. Dr. Tamer.
Okay. So we have some questions for Dr. Orkan, and thank you very much for the very rich presentation and elegant talk. First, I'll start with the question of mine, with which you have started before we go live, about the prerequisites or the requirements for pediatric surgeons to perform a liver resection. What is the required training?
Actually, pediatric surgery is unfortunately very weak on hepatocellular tumors. Per 10 million such as hepatocellular carcinomas. So, it's also limited to biliary atresia and colorectal cysts and so forth. So, unfortunately, hepatobiliary training in pediatric surgery is not quite strong. So, if any pediatric surgeon wants to do a formal and formal liver surgery and become experienced on this, this requires formal training on hepatobiliary surgery, and which can be which we can get from general surgeons, because they're more experienced, they receive more cases, then there is a continuous inflow of hepatobiliary cases in general surgery. So yes, I think the best way to improve oneself in hepatobiliary surgery, in pediatric surgery, is to take a formal training, preferably in a transplant unit. But if not, hepatobiliary unit of a general surgery, which has a high volume of these cases. By the talk of Hisham and also some slides that I have shown, I believe personally that if not all, a pediatric surgeon who's going to do a liver surgery should have some knowledge, at least some knowledge of transplant surgery as well, because this is crucial. There are many tricks in transplantation that you do not do in conventional hepatobiliary surgery. So you should know about all of those, such as vascular controls and intrahepatic dissections and use of ultrasound during surgery and so forth. So this comes as a whole, as a package of training. And I think this is the best way to.
Can I comment as well?
Can
I comment as well, Tamer? Because
sure.
I've seen the comment of Dr. Sharif. In many parts of the world, they see how it is. This is the truth. The volume of pediatric surgery patients needing liver resections and hepatobiliary surgery in general is not as large as the adults. So the only way, I guess, is to centralize the service. Because it's not wise or logic to have many centers all over whatever country that you are in, doing a small volume of cases, and so you will not get experienced. You have to centralize the service. You have to make these small bits and pieces everywhere the country, shift them to 1 or 2 centers, and this is how it goes to get more experienced.
Well, thank you. And Dr. Orkan, are you with the idea of centralization?
Yes, I am, but it's not. It's a government policy. So, of course, I mean, some countries have managed to centralize their hepatobiliary experiences and created center of excellences. But as I said, this is a government policy. In many countries, this is not possible. This is the ideal way to do it, but it's not possible. So, but I believe that at least, even if you cannot centralize the system, you may create centers of excellence. So eventually the patients will drain there. So if it's not done by the government, it can be done by the centers, by concentrating on the cases and creating the center of excellences.
Oh, totally agree. Okay, so we have a question about the use of laparoscopy in resection, and what are the selection criteria do you personally use to select patients to apply laparoscopy for?
I have only attempted to do lateral sectorectomy, although I know very experienced general surgeons on hepatobiliary surgery have gone into laparoscopic resections of right lobe and left lobe. But even in the open surgery, you know how hard it is. So, I mean, by looking at our series, for example, which is a very large series in Turkey as a center, at least a remarkable one, you can still see the total number in 10 years. So it's 80 some cases, okay? General surgeons do 80 some cases in 2 months. We do it in 10 years in pediatric surgery. So, I mean, yes, you can do a laparoscopic resection of the liver, but I don't believe this is good for the patient if you're not quite experienced to do it in laparoscopy. So lateral sector is simpler and feasible for pediatric surgeons to do it. But robotic surgery may change the things. I mean, the wide use of robotic surgery.
I was about to ask about that.
Right, because robotic surgery is a closed open surgery. It's totally different than laparoscopy. The flexibility of the instruments, the management of the arms of the robot is so different. So getting experience in robotic surgery may change things and doing hepatic resections. However, for now, at least, I will, I guess, personally stick with lateral sectors, and attempting right hepatectomy or extensive resections by laparoscopy, even though I'm an experienced one, I don't feel enough qualified. I'm not that courageous yet.
Okay, so it's the best for the patient after all.
Right, it's the best for the patient, yes.
We have another question for you about your personally preferred device for liver parenchymal dissection.
I do a classical clamp crush system. Of course, as Hasham mentioned, CUSA is perfect. However, I use only clamp crush and bipolar. And it's fast enough. And if you have the control and if you have the appropriate navigation in the liver, you don't get into trouble too much. So we have CUSA in our transplant unit, but not in pediatric surgery. But even in transplant unit, we don't use the CUSA. The donor hepatectomy is also done by crash system, clamp crash system. This is my
Yeah, I think this technique is even easier in children in pediatric liver.
Yes, because the liver is thinner than adults, for example, and
it's very soft.
Oh, especially in infants, it's so easy to crush with the clamp and then control the small vessels, so forth. So I don't see why not. It's feasible, I guess. It's cheaper, at least for countries.
Yes, okay, exactly.
Such a rich country.
So another question about the what is particular about the caudate lobe of the liver, if it's included or not in a liver mass?
Caudate lobe involvement change the pretext staging. If, for example, only caudate lobe is involved, it's directly stage 2, not stage 1. Although single sector is involved, single segment is involved, it's still stage 2. So that requires neoadjuvant chemotherapy in terms of cycle recommendations. And caudate lobe is hard. It's not easy, even for hepatobiliary surgery, because its venous drainage to the cava is totally different than the right lobe and the left lobe and the lateral sector. So if you're going to attempt a caudate lobe resection, you should know transplantation. This is one requirement. This is very important. Caudate lobe is very hard, both to access and to control. I don't know what Hisham would say.
It's a total nightmare.
It's exactly. It's hard. It's very hard.
Okay. So another question about the management plan of hepatoblastoma. What's your experience, when to go for chemotherapy first or surgery first?
I still prefer, I mean, for stage 1 patients, there's no doubt. You can still do surgery in pretext 1 cases, both in SIPO and COG. However, if the tumor is advanced, like stage 2 and stage 3, you always have a possibility to leave behind a tumor, a section with tumor residue, either microscopic or macroscopic. So this advances the stage. Plus, why take risk? I mean, if there is this neoadjuvant chemotherapy that reduces the size, that reduces the vascularity, and that delineates the margins of the tumor better after you apply the from the neoadjuvant chemotherapy, why take risks by leaving the macroscopic or microscopic residue behind and then try to stage afterwards and do a secondary surgery maybe? So I'm very happy with SIPO system, because it's not the courage of the surgeon to go in and say, I can resect this. It's not that. The best thing is to think about the benefit, the best of the patient. So reducing the vascularity, reducing the size, limiting the resection area is possible by doing a SIPO approach.
Okay, thank you. Another question about trauma patients. Do you have any experience with hepatic resection for trauma patients?
Yes, we had several. Because sometimes you get, I mean, livers like grinded livers because of the high volume, high velocity traumas. And you have to be very fast. And if you do not feel that you can compete with that bleeding and the high-speed resection attempt, it's best to package the patient first. Pack the patient, stabilize the patient, and then attempt a secondary resection. This is safer for me, I guess. Of course, you could do a primary resection, but you will have lots of bleeding, and then the patient may go into DIC and so forth. So depends on experience, but you have to be very fast and you have to be very experienced on hepatic resection and trauma.
So is there
it's very bleeding, and it bleeds. It's really flow of blood.
Are there like any planning or tricks you need to apply while you do that?
Vascular control is crucial, as Hisham mentioned. Both inflow and outflow vascular control is very crucial. If you do a partial vascular control, if you can manage with partial control, it's perfect. But if not, you have to do a total vascular control. But in these trauma conditions, in a very excited position, patient is, low in blood pressure, low in blood volume, and you have to go in very fast. It's not very easy to perform a total vascular control. So it's again, the experience. And if you don't have the experience to attempt the high-speed vascular control, it's best to pack and do a secondary surgery to stabilize the patient, I guess. That's my approach.
So thank you. So one last question about benign lesions like hemangiomas. When do you go for resection and when to conserve?
We usually do an expectant therapy, and for the hemangiomas and hemangioendotheliomas, we use beta blockers. to reduce the size of the hemangiomas, and they usually respond well to it. And we regularly attempt resection for that. The only indication is the bleeding into the lesion, or the Kasabach-Barrett. So if you have these conditions, you may attempt for surgery. For the disseminated hemangiomas and hemangioendotheliomas, transplantation may be the best choice.
Maybe the answer, yes. And is there any way to expect which lesions are going to go into complications, like the size, or?
I don't know. I don't know any specific indication for that, and I don't think it's associated with the size, because standard hemangiomas, regardless of the size, it responds very well to the beta blockers. So in a month, it reduces in size and it's more controllable. So you should be okay. Close follow-up is essential, but you can be very expectant in hemangiomas. Attempting surgery may not always be the best choice.
Let me just comment here that don't forget that the multifocal ones, they compete with the with the T3, and they lower the T3 and T4. So just remember to measure the T3, T4, and TSH in those patients, and it's crucial to give them hormonal replacement therapy.
Okay. So there is a related question about interventional radiology for like hemangioendotheliomas. Actually, the question is for both of you.
Hemangioendotheliomas, sorry?
Interventional radiology for the management, whether when to go for it and how effective is it in your experience?
Unfortunately, hemangioendotheliomas, they present in the very early infancy. They are very small babies. And whenever I contacted the interventional radiologists, at least in Egypt, they say that we don't have the instruments suitable for the size to go and embolize specifically or selectively and the left hepatic artery, for example, or the right anterior or right posterior. So usually they are out of tricks.
And for you, Dr. Orkan, you have a different experience?
I don't have a personal experience, but I know that our interventional radiology are very skilled and they have the instruments for that. But there's also one trick. Before our interventional radiology was so experienced on these cases, we did a open approach to place the catheter, and then we do the chemoembolization or radioembolization of the patient. So if interventional radiology, if we need to do surgery or any intervention for hemangioma, hemangioendothelioma, there's always the open choice. You can go in open, place the catheter, and they can do what they want to do.
Well, thank you. And there are some other questions just now about the management of hemangiomas too. About hepatic artery ligation, is it effective? Have you tried it, Dr. Orkan?
No.
No. Dr. Hisham?
No.
No. Well, I mean, theoretically, it should be. I mean, if it's bleeding, or if it's receiving, you know, or it leads to cardiac failure, then you can attempt that. But I never had to do it.
Okay. Well, thank you very much for the rich discussion, and I think this is the end of the questions I have. Dr. Mohammed, do you have any other questions?
Just one question, Tamer. About the role of portal vein embolization in hepatic masses. It is open for both, Dr. Hisham?
Well, we've tried a couple of patients with our interventional radiologist. We do this when you have the future remnant liver is small enough that it will not suffice the patient after doing surgery. So we've tried a couple of patients doing hepatic portal embolization. It goes both ways, or it has a double benefit. It shrinks the tumor size because it deprives the tumor from its blood supply, and it also increases the size of the future remnant liver for the next procedure, and it went very well. I mean, for our patients, it was a game changer.
Okay, Dr.
What was the indication, Hashim? what was the indication for intervention?
The CT volumetry for the future remnant liver was small. It was not sufficient for the patient, so we had to do something to increase the size, because again this patient was not amenable for transplantation. He didn't. I'm sure you know that in Egypt we don't have a cadaveric program. We only have a living related program. So if you don't have a donor, that's it. You're stuck.
Okay, that's because I was going to ask, why did you have to use it? Because there is always
we don't have a cadaveric program.
That's clear now.
This is the last question. We will shift now to Professor Ahmed Khairi, please. To Ahmed Khairi. To Sharif.
Yes, Mohammed.
Any other comments from the floor, from the audience? Sorry.
Actually, we are done with the questions, and
if anyone,
we can conclude.
We have Ahmed Al-Gindi, our colleagues from Tanta. He has a good experience in the hepatoblastoma series of 57357 hospital. If he would like to add a comment. Ahmed, are you here? Hello, Ahmed. Dr. Ahmed Al-Gindi, are you with us?
واضح انه مش موجود.
He's not here. Okay.
I think
Dr. Sharif.
I think we reached the end of this session, Akram.
Yes, Dr. Sharif Shahata.
Dr. Suleiman, anyone can close the session.
At the end, on behalf of EPSA, I would like to thank all our speakers and attendees today who really enriched this meeting by their discussion and the priceless information we have gained today. It really warms the heart to see such a great number of our colleagues sharing their opinions and expertise despite the hardship of our world is suffering from. And as I have been always saying in recent webinars, had it not been for COVID-19 and putting your safety first, demanding social distancing, we would have held this meeting as we used to, meeting in person and welcoming you face to face. We ask Allah, the most merciful, to put an end to this serious pandemic and help us to return soon to our normal life and to protect all our colleagues and their families all over the world. I am also honored that I was to host this section of surgery leading figures, and I wish this webinar did not come to an end to continue to listen to this juicy speech. Finally, I remind you that a recorded version of this webinar will be available on the EPSA's YouTube channel very soon. Now I am leaving to Professor Sharif Shahata. By this warm words.
Thank you, Dr. Suleiman. I have to thank both our eminent speakers, Professor Hisham Abdelkader from Egypt, and of course my close friend, Professor Organ, the president of the TAPS, for his marvelous presentation and advanced experience. Until we meet in person, inshallah, hopefully in Shishma together or in Alexandria, doesn't matter. I have to thank all the participants for the continuous with us for this 1.5 hours. Until see you in the coming March webinar for the EPSA. Thank you all.
Thank you.
Thank you very much. Have a good night.
Thank you very much.
Shukran Gazin. Thank you, everybody.
Have a good night.
Thank you, Akram.
Bye.